For this topic, I wanted to jump into some of the important pointers behind documentation, billing, and coding for the inpatient world. Because this can be such a fast-paced area where you are in and out of patient rooms, charting when you can. That's not to say that in other areas they aren't doing the same thing. But if you have a little bit of a reminder of the importances of certain elements of documentation as well as the billing codes that correspond with the care, it it would be a good reminder to support your practice as well as prevent any of your charts being sent back to you and future audits or claim denials. So as far as the hospital admission goes, there are 3 levels of CPT codes for the initial admission based on time spent with the patient as well as medical decision making. These are your 99221s through 99223s. And I will say primarily the billing codes that we see for admitted patients are going to either be the 99222s or the 99223s. And the same goes for the hospital progress note, either the 99232s or the 99233s. It's most common that admitted patients will either be a level 2 or a level 3. However, that doesn't mean an admitted patient won't be a level 1. It's just less common and less likely. When you are, as far as caring for the patient, you're going to fall back on that desk prompt that I have provided in other slides, or one that's previously been provided to you, to determine that level, whether it's a level 1, 2, or 3. Just knowing that it's very uncommon that you'll see a level 1 in an admitted patient. When you are either consulting on a patient that you're rounding on in inpatient care, or you are caring for a patient in critical care, an important reminder is time must be part of your documentation component. And that's time spent either coordinating or counseling with the patient face-to-face or outside of their room, either speaking with other providers, reviewing diagnostics, ordering new diagnostics, etc. And typically, if more than half of your time is spent doing coordinating or counseling the patient, time can be used to support the billing code selected. And typically, if you are used to the inpatient world and you are comfortable in that practice, you're using a templated note. And if it's not already, it should be part of your template that you actually have that phrase in there stating how much time was used coordinating care and counseling the patient. So just know that that needs to be a part of that documentation, that note for the service that you provided that day. When discussing progress notes of the inpatient world, your progress note needs to paint a clinical picture of the patient and justify their continued hospitalization. If your progress note doesn't suggest any reason for hospitalization, that claim for the inpatient status will likely be denied. So it does need to support what continued efforts are being used to help the patient's current status. And I just want to remind you, as well as every other provider in any other area, when you are using templated notes, typically those templated notes get pulled over from the last progress note, and to be mindful of any changes that have occurred with the patient. So if you say the patient's respiratory status has not changed yet, they were placed on BiPAP or high flow oxygen, as a couple examples, this would not accurately reflect the patient's status. And it's not uncommon to see at the top of the note, the patient had no changes overnight. However, at the bottom, you indicate they were, like I said, placed on a BiPAP, for example. So just be really mindful when you are using a templated note or pulling over that progress note from the previous either provider or the previous visit, that you are addressing any changes that occurred with the patient, and you're just being very cautious that you are not documenting perhaps something that is within normal limits that is not within normal limits for that patient, because it's so easy to be so busy and have template fatigue where we tab through, we quickly go to what we want to say down at the bottom of the progress note, and in fact we're saying that something is normal for the patient that is not, etc. And then lastly, a big part of the inpatient care is going to be your discharge summary. This discharge summary essentially wraps the patient up in a bow, states their reason for admissions, their clinical findings on diagnostics, their current condition as they discharge, and the follow-up plan of care. That cannot be stressed enough. It is so important that we discuss or we address what the follow-up plan of care is for the patient moving forward. Do they need follow-up? They may only need follow-up as needed, or if any changes, or perhaps you want to see them in clinic in the next 2 days, or perhaps they have staples or sutures in place and you have a specific time frame in mind that you have indicated that will be printed out with the discharge packet when they need to be seen again. It's very important that we have that follow-up plan of care noted. And also, the discharge summary is not a place to discuss new information, new changes, or new findings without a plan of how we are going to address that. Perhaps the patient on the day of discharge was not able to wean off of oxygen and is requiring 2 liters of oxygen and will be sent home with oxygen. What's the plan moving forward? Are they going to follow up with their primary care provider within the next 2 weeks to discuss their respiratory status? It just needs to be addressed. This is a new finding for the patient. They're requiring oxygen. However, they're otherwise stable, able to go home on home oxygen, and I have advise the patient to follow up with their primary care within the next 2 weeks to discuss respiratory status moving forward. It doesn't mean that the patient can't have a new finding, perhaps a new finding on diagnostics that needs to be addressed in the future. Yes, they are stable enough to go home, but what are we doing about this new finding? So when I say that we don't document new information or concerns, certainly new information or concerns can arise, but we just want to address that we acknowledge this is new for the patient and what the plan is moving forward and that they're stable enough to go home. And the reason I bring that up is I did find that this was a reason for claims to either be denied or audits and charts to be sent back to providers, in that a discharge summary stated a new condition for the patient without a plan of care for that new condition moving forward. So I just wanted to reinforce that we're cognizant of any new changes and what the plan is for that change in condition moving forward.